At this time, we're happy to present Screening for Breast Cancer: Why, Who, What, When, and Where with Dr. Harriet Borofsky.
Thank you very much, and good afternoon, everyone. Thank you for joining us for this webinar. For those of you that don't know me, I'm Dr. Harriet Borofsky, privileged to serve as Medical Director of Breast Imaging at Riverview, Bayshore Medical Centers, and at Eatontown, a relatively new outpatient satellite site. And I work alongside my esteemed colleagues, Dr. Dennis D'Angelo, Dr. Sokolovskaya, and Dr. Ko. As we all know, it's October, which is breast cancer awareness. What an important topic to talk about. And I thought I would address the W's regarding screening for breast cancer. Why, who, what, when, and where should we be screened for breast cancer? Why is this topic so important and so crucial to know about? Well, I don't think it needs to be October to be aware of breast cancer. I am certain breast cancer has touched the lives of every single one of us in one way or another on this webinar today. Breast cancer knows no socioeconomic, political, religious divides. It is a global health problem because it is the most frequently diagnosed cancer in women worldwide. The American Cancer Society estimates that there will be 2.3 million women diagnosed with breast cancer this year, nearly 230,000 women in the United States, and 8,330 women in our beautiful garden state of New Jersey. Sadly, it's a major cause of cancer deaths in women, second to lung cancer, with nearly 690,000 deaths per year worldwide, almost 40,000 in the United States, and 1,250 in New Jersey. And don't forget, young women get breast cancer. In fact, it is the most common cause of cancer deaths in women ages 20 to 59. And this is from the CDC, reminding me to tell you that the state of New Jersey is one of the 10 hotspots or top 10 states with the highest incidence of breast cancer in the United States. I don't know why, but those are the facts. And then if you look at this map from the New Jersey Department of Health, you can see that Monmouth County, certainly where I live and work, is also one of the counties in New Jersey that has the highest incidence of breast cancer. Here's the good news. Breast cancer is highly curable when it is found early. The 5-year survival rates when it's localized to the breast, as it is about 62% of the time, is 99%. Almost everyone has a 5-year survival. When it involves the breast and lymph nodes on the same side, as that occurs 30% of the time, the 5-year survival rate is 86%. And when it is distant, by that I mean breast cancer has spread outside the breast and regional lymph nodes, when it's somewhere else in the body, you can see the 5-year survival rate goes down to 27%. Overall, women who are diagnosed with breast cancer have a 90% 5-year survival rate and beyond. So why do we screen for breast cancer? Well, the answer to that question is breast cancer meets appropriateness criteria for screening, just like we screen for diabetes and hypertension, because number one, as I've just told you, it's common. Number two, it causes deaths, and we want to prevent those. And number three, breast cancer is a progressive disease, so that early detection through screening is an opportunity to halt that natural progression of this disease, increase treatment options, including many treatment options which are minimally impactful to women's lives, all outpatient and often without chemotherapy. And of course, our ultimate goal is to save lives. What is the screening test for breast cancer? Well, we hear about all new modalities, And the mammogram remains the only screening test proven to reduce deaths from breast cancer. It remains the main imaging modality and starting point for breast imaging. And a mammogram is appropriate because screening tests have to also be inexpensive, quick to perform. Doing a screening mammogram takes about 15 minutes, safe and well tolerated. And we'll talk about how we can improve upon the tolerance of mammograms, accessible to all populations, and highly accurate. What's the proof of benefit? Well, the gold standard for any screening test is something called randomized control trials, where you compare large populations when we're going to take screening for breast cancer of women invited to be screened. In other words, they received invitation, and these studies were done in the 1960s, 70s, and 80s, and large populations of women who did not receive invitations to be screened. And then you compare the death rates from breast cancer from those groups of women. And those studies that were conducted 1963 to 1982 showed a reduction in deaths from breast cancer. And that wasn't 1, 2, or 3, it was 6 to 25 to 52%. And remember how long ago those studies are. That's before the current technologies that we have. So it's expected that screening for breast cancer reduces death rates more than that. The estimated reduction in deaths from breast cancer since screening in the United States started in the 1990s is estimated to be 41%. And the major shift that I have noticed in my career is really a paradigm shift in treatment of women with breast cancer towards early stage. Lumpectomies are done very often instead of mastectomies. When I started my career 2.5 decades ago, women were having axillary lymph node dissections. Now they are not, because most women don't have lymph nodes involved. They're having sentinel lymph node biopsies. There is a general trend toward what we call de-escalation of treatment, actually doing less, sometimes foregoing radiation therapy and chemotherapy if it's safe to do so, because we're finding breast cancer in such early stages. Thank goodness. I do want to let everyone know the current standard of care is a 3D mammogram. There should be no reason to do a 2D mammogram in the year 2024. Probably in my career, this is the single most important and impactful technology. Simply put, it is a way better mammogram. Instead of a single exposure, as we're used to in the past, the tube moves across the breast and creates multiple exposures that are reformatted in my computer like a CT. So I'm able to look at the breast in cross-sectional images. It is the same dose as a 2D mammogram, but with an increase in breast cancer detection, 15% to 53% in the multiple studies that were performed, while at the same time decreasing the number of women who had to come back for extra views or additional views by 15% to 37%. So make certain you're getting a 3D mammogram at most sites. Certainly at ours and at HMH, it is the only mammogram that is performed. The other new and exciting thing at HMH is that all of the sites this year were replaced with the next generation of 3D mammograms. These are basically higher resolution images because the pixel size, the very, very small dots that compose the image have been made smaller. So the images are very high resolution, and the units come with a curved compression paddle, and many women have noticed the difference because it's a gentler compression and gentler mammogram. And I just wanted to share the difference. On the left is our old technology, and on the right is the new, and this is a phantom image, and you can see perhaps that it is a higher resolution, high contrast image, which is incredibly helpful when we are looking at subtle areas of architectural distortion, these radiating lines that can be an indication of cancer. are certainly more conspicuous here with the next generation high resolution 3D compared to our old technology. And one of the things we look for when we're screening for breast cancer are very subtle powderish calcifications, which you can clearly see here and not with our prior resolution. So fantastic technology. I am certain you have all heard about AI, artificial intelligence. It's everywhere, and it is here at my sites, Riverview, Bayshore, and Eatontown, and across HMH. These new units come with AI, so the radiologist reads the mammogram, and as we're toggling through the case at the very end, we get the read from the AI. We get a K-score to let us know the score, how concerning the mammogram is for the presence of cancer. And anything the computer sees as potential for cancer, it marks. And it also marks the probability that the finding could be cancer. So it leverages deep learning. So it's constantly learning to help us find more cancers and enable workflow efficiencies. Some sites, for example, are assigning those cases that have a higher K-score to those expert breast imagers. Some cases with high K-scores are read first before others. I know we don't do that at our sites when I'm going through a mammogram and it looks normal to me and the AI reads it as normal, I feel very comfortable putting that case through. And I am very, very glad to have that assistance from AI because I'm a human being. I get tired, I get distracted, and I really feel like this enhances patient care. So we're very excited to have this and offer this. So if mammograms are so important, and that's why we do it, what percentage of screening age women in the state of New Jersey are up to date with their screening mammogram? And this is specifically women of screening age and women who have had mammograms in 2 years. And in the state of New Jersey, 23.2% of women have not had their mammogram. And in Monmouth County, 22.3%. So we have room for improvement. Get the word out. How might we break down barriers and obstacles and disparities for screening? All of our sites are working on this at HMH, certainly the sites where I work. What we've done to try to get women in, you actually do not need a prescription to have a mammogram because that's an obstacle for care. Some women don't have a physician. Some women do, and they can't get in for 2 or 3 or 4 months, and they're due for their mammogram. So you don't need to have a prescription when you come in for a screening mammogram. You do need to have a prescription if you're coming in because you have a problem, such as a lump or a nipple discharge or focal pain. We launched online scheduling about 1.5 years ago, and that makes it just super easy for women to schedule their screening mammograms. I know for me personally, my obstacle for scheduling anything is phone trees and making a phone call. With online scheduling, any woman can go on after work when she's at home, go onto our website and schedule her screening mammogram. We also have text reminders that are sent out when women are due. I got mine last month on my phone. It was a text message that I was due for my mammogram, and I click and it puts me on the site to schedule my mammogram. What a great way to break down obstacles and barriers. We have convenient hours for women, including early in the morning. Our first mammogram is offered at 6:30, and we go later at night till 7 o'clock. We have Saturday appointments. We have translator services where we have women here who can provide translation directly with patients, and we also have computer translation services. Diversity of care team members is so important because we want everyone to connect and feel comfortable and put their trust in our care. So we're working on that. We have pink funds from our foundations, both at Bayshore and Riverview, which fund uninsured or underinsured women for screening mammograms and breast imaging, and seed funds from the state of New Jersey. We do provide same-day reads for those women who really want to have the results before they go. Timeliness of results and scheduling any follow-up really need to be prioritized to decrease anxiety surrounding these exams. And we offer women to schedule for their next appointment on their way out again, so it's done and it's on the calendar. I thought I would briefly talk about my ideas for helping to prevent discomfort during a mammogram. First, if you're premenopausal, schedule your mammogram during the first 2 weeks of your menstrual cycle when the breasts are less sensitive and tender. If you have sensitive and tender breast tissue, take Advil, Motrin, Aleve, or Tylenol before the exam. It's perfectly safe. It may help hugely. Be as relaxed as possible. We all know that having a mammogram is such a high anxiety, stressful exam, but really try to talk through it. Know that your technologist is a professional. Trust your technologist. They are here because they are completely and utterly dedicated and very experienced. I suggest to my technologist, especially in women who have sensitive, tender breasts, a slower graded compression, and that is manual compression. Is this okay? Can I compress a little bit more? And the smart curve compression paddles really help as well. Mammograms are not perfect. No imaging test is. There are limitations. Mammograms do have a reputation for unnecessary anxiety because of recalls and biopsies, leading to stress, costs, like I said, anxiety. We call back 10 to 16% of women who have a screening mammogram. That's that dreaded phone call to come back in for additional views. Please remember, if you get called back in, the chances that you have cancer are low, 6.5%. And when we recommend a biopsy because we see something we're uncertain about that meets our threshold for taking a sample, 80% of the time it's benign. We find cancer about 20% of the time. And mammograms don't show all breast cancers. A breast cancer may be missed, which may lead to a delay in diagnosis. Approximately 6 to 10% of breast cancers don't show up on mammograms, including 3D mammograms, especially in our highest risk women who have dense breasts. And these missed breast cancers tend to be more aggressive for reasons that we don't know for sure. So I wanted to remind everybody, having a negative mammogram does not mean you do not have or will never have breast cancer. It means cancer has not been found, which is why we have other supplemental imaging modalities for screening that I just wanted to touch upon. The most common additional modalities or supplemental screening that we use are breast ultrasound, particularly helpful for doing additional screening in women who have dense breasts. This is almost becoming standard of care. Most of the time it's handheld. A technologist will be scanning your breasts with her hands. Some are automated, which is a larger paddle, which is automated to go over the breasts. We use breast MRI in a select group of high-risk women. You have to have a lifetime risk of 20% or above. That may be related to family history. It may be related to prior biopsies with atypia. It may be due to a history of Hodgkin's disease and irradiation. It may be due to you have a known genetic predisposition or you have it in your family. And a newer modality that we introduced about a year and a half ago is a contrast enhanced mammogram. And for those of you that may not heard about this because it's relatively new, it is a mammogram that combines the very high resolution images that I showed you, along with functional imaging that we get like an MRI when we give contrast. It is the nature of the most aggressive tumors to bring in abnormal vessels, and the contrast allows us to see those abnormal vessels in imaging. So how it works is a patient sits in the mammography room, an IV is started, she gets the contrast. It's sort of similar to an MRI in that regard, and we actually get a low KV regular mammogram that looks like this. There is a high KV exposure that shows the mammogram plus contrast. And we also see the subtraction image, which shows those areas that take up the contrast. And this is what a cancer looks like on a contrast enhanced mammogram. So we use a contrast enhanced mammogram as an alternative to MRI. It's a lower imaging cost, much shorter imaging time. There's no pre-authorization. It's basically a diagnostic mammogram with contrast. The radiation dose is equivalent to a diagnostic mam, and it's very fast, well tolerated, and easily incorporated into our program. And it's really for those women who may not be able to have an MRI. MRI is still the gold standard because they're claustrophobic, or they have a pacemaker, or they can't get authorization, or the cost is prohibitive, or perhaps due to their body habitus. So we did the whys, we did the what, we're on the who. Who should be screened for breast cancer and when? Well, there are many risk factors for breast cancer, but sometimes we forget the two most important risk factors are having breasts, therefore being a woman, and getting older. 75 to 80% of women diagnosed with breast cancer have no additional risk factors beyond their gender and age. And you can see on this graph, at about the age of 35, the incidence of breast cancer in women goes up as a straight line. And we just start screening at the age of 40 because that's when breast cancer becomes more common. So that's why we start at the age of 40. Some women, however, are at high risk for breast cancer. Who are those women? Those women who already have a history of breast cancer have about 3 to 4 times higher risk. Those women who have relatives with breast cancer, first degree, 1 first degree 2 times, greater than 1 first degree 3 times, or a male relative with breast cancer, 2 times the risk. Those of us that have dense breast tissue, and it's 50% of us, are at about 1.45 times higher risk. In those women who have extremely dense breast tissue, they're at twice the risk than their girlfriends with fattier breast tissue. If you have a prior biopsy with atypia, particularly atypical lobular hyperplasia, you're really at higher risk, 4 to 10 times. If you have exposure to chest radiation at a young age, 4 to 5 times, and if you've inherited a genetic mutation, most commonly BRCA1 or BRCA2, but there are many others, you're at 4 to 6 times higher risk. There are certain risk associations which may be related to our hormonal milieu or a number of ovulatory cycles, early age at first period, late age at menopause, no children, hormonal therapy with estrogen and progesterone may promote breast cancers, postmenopausal obesity, and alcohol consumption. So I thought I'd remind everyone that there are ways to reduce your risk for breast cancer, 3 ways. Number 1, maintain a healthy body weight. Studies have shown that if women achieved a BMI, body mass index of less than 25, 16% of breast cancers, there would be a 16% reduction in breast cancers. That's a big number for the female population. Limit alcohol intake. The 2008 Nurses' Health Study showed a relationship between alcohol consumption and breast cancer. And engage in physical activity regularly. A meta-analysis of multiple studies found that regular physical activity reduced the risk of breast cancer by a whopping 22%. So adopting these 3 prevention strategies may reduce your risk of breast cancer by 22%. And it also just increases your health. It's a healthy lifestyle, basically. These are the current average risk screening recommendations. Average risk women should be should start their screening at the age of 40 and annually after that. And then we continue screening women. And I hear this question all the time, even today. A 76-year-old asked me how long she has to continue having screening mammograms. Here's my answer. Screening mammograms are for healthy, vibrant women who have a life expectancy of 10 years or greater. And we know we're living a long time. If you have a first-degree relative with breast cancer at a young age, and that would be a mother or a sister, we begin screening 10 years earlier than that age at diagnosis. And if you're high risk, and particularly if you have dense breast tissue, supplemental screening with ultrasound, MRI, or contrast-enhanced mammography may be indicated. So, how do we know our risk? Well, a risk assessment for breast cancer should be performed in all women by the age of 25 to 30. Why is that? Certain women who are high risk or have genetic mutations, or their mothers or sisters have genetic mutations, we begin screening them at 25. We start at MRI at the age of 25, and when they reach the age of 30, we add mammograms in along with their MRIs. How do you know your risk of breast cancer? Well, last December, we launched and implemented risk reporting. Every woman who comes in for her mammogram has her lifetime risk for breast cancer reported. We have a computer software program that does that for us. It's called the Tyrer-Cuzick version 8. It incorporates the woman's age, family history of breast and ovarian cancer, reproductive history, biopsy history, BMI, because of the relationship with obesity to breast cancer, and breast density. And we're able to give the lifetime risk for breast cancer, whether it's 4%, 16%, 20% or higher. Any woman who's 20% or higher is at high risk. It's our way of proactively identifying women who are at high risk for developing breast cancer and therefore may need imaging beyond screening mammograms, and women who have a probability of a hereditary predisposition, like a genetic mutation, and that way we can appropriately refer them for genetic counseling. And what this does, it informs a personalized, risk-based approach to screening. By that, I mean screening used to be a one-size-fits-all, women 40 and above have a mammogram. Not so anymore. All women start with a mammogram every year, 40 and above, but some women may need a mammogram and an ultrasound. Some women may need a mammogram, ultrasound, and an MRI or a contrast-enhanced mammogram, and risk reporting allows us to personalize screening recommendations for each woman. So it also complies with new insurance authorization requirements for breast MRIs to be authorized. They require the lifetime risk for breast cancer. And most importantly, it improves the quality of care for early detection and prevention of breast cancer. And then I'm going to get to our last question, where? Where you have your mammogram matters is our mantra. And because it really, really does. The quality of care is not all the same. And you really want to have your mammogram at an ACR designated, that's American College of Radiology, Comprehensive Breast Imaging Center. These are breast imaging centers that have been inspected and are accredited for mammography, breast ultrasound, ultrasound guided biopsies, stereotactic biopsies, and MRI. That is your assurance that this program is dedicated to these technologies and is accredited, has been inspected, and others think that it is dedicated. And you want to have physicians who are specialized in breast imaging, technologists who are experienced, specialized, and dedicated, nurses and support staff that are experienced in what they're doing and providing compassionate care. You also want to make sure that you have access to what I just described, multimodality screening, mammograms, ultrasounds, contrast enhanced mammograms, MRIs, minimally invasive biopsies, and backed by a multidisciplinary team of breast surgeons, oncologists, breast radiation oncologists, genetic counselors, social workers, nutritionists, nurse navigators to support your care, and most importantly, to provide continuity of care. And that's my talk for this afternoon. I thank you so much for your attention. I hope that I shared important information that will inform you, your friends, your relatives about screening for breast cancer. And I'm very glad to take any questions or comments you may have.
Dr. Borofsky, there are a few questions that were submitted. When should a woman get her first mammogram?
If she is of average risk, by that I mean mother or sister did not have premenopausal breast cancer, then the answer would be starting at the age of 40. So most women start at the age of 40. If mom or sister had breast cancer at the age of, let's just say 40, then screening begins at 30. And some women start screening at the age of 25. These are mostly women who have known genetic mutations like BRCA1 or BRCA2, or their first degree relatives who haven't been tested. We start doing MRIs at the age of 25 and then yearly, and then we start their mammograms at 30.
Is it safe for senior women to stop getting mammograms?
Well, like I said, it depends on how you define senior, because age is a funny thing. Mammograms are for healthy women of all ages who have a life expectancy of 10 years. So probably, if you're in very, very poor health, even at a young age, probably having a mammogram, a screening mammogram may not be appropriate. If you're 95 years old, it's hard to improve upon your longevity by doing a screening mammogram. You don't need to be screened. Let us know if you feel a lump. But there is no end age because women's health is so variable. So life expectancy of 10 years is how I like to answer that question.
Is postmenopausal breast pain a sign of breast cancer?
Very, very infrequently. So pain is probably the most common symptom or worrying concern that brings women in. And we very infrequently find a reason for that pain. We find other things, and sometimes we find cancers unrelated to the pain. But for the most part, pain is not a symptom of breast cancer. If it's focal, we always like to check it out, but don't be too concerned. And we feel very differently about lumps. Most lumps are not cancer, but we consider a lump a cancer until proven otherwise. So I would suggest if it's breast pain and it's unusual for you, come in and get it checked out, especially if it's in one area. But don't be too concerned. Most of the time, it's normal and it's not an issue.
Is it true that if one has never had a full-term pregnancy, that person is at high risk for breast cancer?
I wouldn't say high risk. It factors into all of those components that determine our overall lifetime risk. I think not having children is a small component. It may elevate your risk a bit, not into the high risk category unless it's combined with other things. Like, for example, if you have extremely dense breast tissue, you've never had children, and you have an aunt with breast cancer, that might put you over the 20% threshold. So that could, but as an isolated risk factor, it's important, but it doesn't create a very high risk. And it's something that you can't alter anyway.
How do breast implants affect mammograms?
So lots of women have had augmentation and have implants, and we do their mammograms. It does require 2 times the number of views. So each view that we do it twice, one including the implant and the other pushing the implant back and bringing the breast tissue forward to try to get as much breast tissue as possible, because the implants in the breast do obscure the underlying breast tissue behind it or sometimes around it. So it does mean you're going to get double the number of views for your mammogram. And sometimes we do supplemental screening for women. If we can't do the implant displaced views, we may add an ultrasound, sometimes an MRI if the imaging is very limited in women with implants.
Okay. Do breast cysts increase the risk of breast cancer? And there's a two-part question. Does how long you have had breast cysts affect your risk? For example, having them in your 20s all the way through your 60s.
So cysts, which are basically fluid that accumulates in normal structures of the breast called lobules, are incredibly common. We probably see small cysts on ultrasound in women more often than we don't. Having said that, some women have really cystic breasts where they have lumps that come and go that are rather large. They do not increase the risk for breast cancer. They do increase the risk of getting called back, needing an ultrasound, aspirations. They definitely complicate the pattern and they complicate the screening process because they show up. And in some women, they create lumps, and you never ever want to ignore a lump, even if you have lumpy breasts because you have cysts. But cysts do not increase the risk of breast cancer, even if you've had cysts from your 20s through your 70s or 80s. I will say we infrequently see cysts in young women. They're uncommon in teens and in 20 somethings, and they start to increase at the age of 35, 40, and beyond. In most young women, we see benign solid tumors of the breast called fibroadenomas more commonly, but cysts do not increase the risk for breast cancer.
Okay. Prescription is not needed for mammogram, but how about if you need an ultrasound right after, depending on the mammogram result? Do you need a script for the ultrasound?
So depending on the site where you go, the radiologist, the doctors, once a woman comes in for her imaging and has it done, that doctor, which is responsible for the read, can order anything to support that patient's care. So if I read a screening mammogram and I think this woman needs to have an ultrasound, I can write that order. So here at Bayshore and at Riverview, we do that. That is not across all of the sites. Some of the radiologists do not write orders just because it traditionally has not been the radiologist, but we are absolutely able to support your care by writing an order, and we do very frequently. If your doctor wants to write the order, that's great. That way we have it and it's there, but the radiologist can do the order for the ultrasound as well. That's not a problem at our sites.
How do you get extremely dense breast tissue?
That is a genetic trait. It is like the color of our eyes. You see my hair. Type of hair, it is a genetic trait, and extremely dense breast tissue. If you talk to women, their mother might be from the mother's side of the family. It could, don't forget, half of our DNA comes from our father's side of the family. So it's a genetic trait. It's unalterable, really, and that's just the way it is. There are some things that can alter the breast composition somewhat, that is in postmenopausal women. There can be some fatty involutional changes that happen after menopause. And if that woman goes on hormonal therapy, we'll see that breast density increase. Weight gain and weight loss can also alter the breast composition as well. Of course, pregnancy markedly increases the breast density and size, and certain medications like tamoxifen can alter the breast density and enhancement pattern a bit. But generally speaking, the composition of our tissue is a genetic trait.
Okay. And the last question is, how does moderate drinking increase our risk?
If you mean the mechanism, I can't really tell you why, but there is an association that's known between alcohol consumption and breast cancer. Women who drink and have a higher incidence of breast cancer. That's been shown in studies. I don't know the mechanism of that.
There are no more questions, Dr. Borofsky. Thank you so much for your time and for sharing your expertise with us. Thanks to all of you for joining us today. Please watch your email for an evaluation survey of the program, and please visit our website, hackensackmeridian.org/events to find out more information about upcoming programs. Enjoy your afternoon and be safe. Thank you.